Welcome everybody to the SAM webinar number 7, sponsored by Inflammatix. Today's title is the COVID-19 pandemic, ED impact before, during, and after. I'm the Chief Medical Officer of Inflammatix, and my guest today is Professor Edward Michelson, who heads the Department of Emergency Medicine at Texas Tech's University Medical Center. Dr. Michelson has more than 30 years of experience in emergency medicine. The Texas Tech location is actually his 5th station in the life of an emergency medicine academician. And he will basically give us and share his wisdom about the impact of the COVID-19 pandemic. Our conflicts of interest are listed here. And to set up our webinar today, I wanted to first give us a snapshot and remind us of the impact of the pandemic as captured here by the Johns Hopkins COVID Research Center. So as of today, we have basically 185 million cases worldwide. This is around 2.5% of the world population. Good news is that more than 3.3 billion vaccine doses have already been given. And when we look at the US in particular, we have 33 million cases with more than 600,000 deaths thus far. And worrisome, or we will talk maybe about that, is that CDC just announced that more than 50% of the current cases observed are belonging to the Delta variant. And CDC also has just released the good news that more than 183 million people in the US have received at least one dose, and 158 million of people are fully vaccinated as of today. So to talk about the impact of the COVID pandemic on the emergency medicine community, again, we will talk with Edward Michelson, and I want to start the discussion to ask Ed to tell us about what actually changed in his emergency department at the beginning of the pandemic.
Thanks very much, Oliver. I really appreciate the invitation to speak today. I also, many thanks to SAEM. I'm joining my 36th year as a member of SAEM, including those years before it was SAM. It was, I think, UAIMS and STEM. And I remember those meetings vividly. So the pandemic has rolled out differently for each of our emergency departments, in part based on where we're located in the country. Here in West Texas and El Paso, it came late to us. I think many of the early cases were in the Pacific Northwest. And then in the spring of 2020, we saw the carnage in New York City. And all of us saw those videos of what looked like mayhem in the ERs in a lot of the hospitals in New York. We weren't there yet, so we were all wondering when it would reach us and what we could do to prevent pandemonium from taking place in our department. The first surge in El Paso began in end of July, beginning of August, around the time we're taping this interview. And fortunately, we had a lot of time to prepare and time to learn from our colleagues from the East Coast to see what they were doing, to participate in certain webinars, and try to get ready. So I think the first phase for us was that preparatory phase when we knew the wave was coming.
Great. So what then, when the pandemic came to your location, what were the initial things that you had to implement or that your team had to implement to make sure you would be kind of implementing the right responses?
Sure.
And changed.
I think for all of us, our first concern was staying in the game. We had to make sure that all of our staff, our nurses, our medics, our residents, our faculty stayed protected and free of COVID-19, not only so that we could stay healthy and take care of our patients, but also so that we didn't take it home to our relatives, potentially some of whom may have been fairly vulnerable. Early on, we made the decision to acquire half-face ventilator masks because we kept hearing about shortages of N95 respirator masks around the country. So we made a large purchase, actually, of half-face ventilator masks that have built-in N95 filters. We made sure everybody was fit tested and knew how to use those. We also beefed up our supplies of other personal protective gear, including gowns, increasing our numbers of gloves, and made sure that everybody knew how to use them. Because if we couldn't keep ourselves free of infection, we wouldn't be able to take care of our patients. We
Right.
also did a number of things facility-wide to prepare for a surge of patients and to try to figure out how to separate those patients who were PUIs, patients under investigation, who potentially had COVID, from those who didn't.
Mhm. Can you elaborate a little bit on the impact on staffing? So were you actually bringing in new staff? Did your ED staff, or did you bring in new ED staff? What about ICU capacities? What happened there?
Yeah, the whole story on staffing was one of evolution. Here, we also benefited from the fact that the pandemic hit different parts of the country at different times because we saw huge movements of personnel, primarily nurses, but we also saw itinerant doctors, if you will, who were able to come and help those areas during their periods of peak time. Our big surge occurred right around Thanksgiving. We'll talk a little more about that later in terms of some of the ways we had to respond. But I would say early in the pandemic, we lost nurses. We lost a few physicians who left, frankly, to go to New York, to go to other areas where they were critically needed at that time. And before we were seeing the big increase in patients.
Mhm.
Then, when we got to the fall and our big surge, we benefited by being one of the first communities in Texas that saw a rise in patients. So we had nurses from many other hospitals in parts of Texas. We had agency nurses that were employed. FEMA stood up teams to help us. They brought in nurses from other areas. And because at that time we weren't competing with Houston and Dallas and Austin, we were able to get quite a few people here to deal with that big surge in population. We also had a response from the mobile medical unit, which is a state-based resource, primarily emergency medicine resource, that came as a fully functional field hospital, if you will. They set up their tents with their crew quarters, generators, and they were able to provide us essentially a 25-bed field hospital in the parking lot. And they were
Mhm.
able to offload the hospital from some of our patients.
Great. I think to really make people understand what the logistics were, I think you have some pictures that were actually taken, how you organized your emergency department, and also separated patients with suspected COVID from those without. And maybe you can talk a little bit about how did you get your regular patients still attended while you were taking care of this huge wave of COVID patients?
Sure, happy to share. Can you guys see the screen?
And yeah, we can see it. Great.
Great. Well, this is how the front of our emergency department changed. Notice the white tent. I'm not sure why all the tents were white. That works very well in the Southwest where we have a lot of intense heat. But we set up multiple tents at different locations in the hospital. We had similar tents at public entrances to the hospital, and we limited those entrances so that everybody coming into the hospital could be screened. All of our hospitals in our region very much limited visitors during the peak of COVID. We didn't want people coming in who were infected and possibly visiting non-COVID patients and turning them into COVID patients. This is, however, the tent that we had at our front entrance, and we stationed a screener behind that mobile screen and computer so that we could do temperature checks, screen visitors and patients as they came in. The goal was to identify early in the visit those patients who were possibly infected with COVID and try to keep them separated from patients who were non-COVID. So to that end, if you notice, looking down our front driveway, you'll see two blue tents. In the beginning of the pandemic, those tents became patients under investigation tents. Anybody with a fever, with a cough, with symptoms concerning for COVID was screened and triaged directly to one of those tents, unless they were grossly unstable. And we had a team dedicated working in continuous PPE in those tents to do the initial evaluation. EMS also would triage pre-hospitally patients who were stable and were directed to bring those patients right into one of our tents and bypass the EMS entrance as well as the triage entrance. 3 of these tents were purchased by our CEO in the spring of last year. And at the time, I thought that was a silly purchase. I never imagined we would use them, certainly not 3. And I have to tell you, 2 of those 3 tents are still up and are still in use today, some 15 months later. The inside of the tents, you can see here without patients. We had a separate triage nurse dedicated to screening those patients. And over time, we filled those tents up with all the various equipment that we needed to take care of non-critical patients. We situated the tents in front of this long party tent that leads to our decon entrance of the department. Obviously, a number of the patients needed to come inside, particularly if they were going to need high flow oxygen, if they were going to need imaging studies. And so we funneled them all through our existing decontamination entrance, again, keeping them away from both the EMS and ambulatory entrance so that they could gain access to the hospital for additional studies. Another concern we had was negative airflow. Early on, our desire was to keep patients wherever possible who needed to be indoors in a room that had negative airflow. Pre-COVID, in a 40-bed ER, we may have had 6 rooms that were designed to be negative airflow. And prior to COVID, those were, primarily for other infectious patients, a patient who you were concerned had TB or other illnesses. 6 was not enough during COVID. Our engineers were very clever. This is an example of one of the rooms that has an outside wall. And you can see that a glass pane in the windows was removed. A box was installed with a simple fan blowing outward and a filter. And with the door closed and that fan running, now we had a negative airflow room. So we created another dozen or more negative airflow rooms by doing these types of conversions.
Ed, can you also remind us of before you talk about the utilization, what was the overall capacity of patients in the hospital and maybe also in the ICU, and what changed during the pandemic?
Right. Our hospital from years ago was licensed for some 350 or 400 beds. Pre-COVID, we were operating about 235 beds. At the peak of COVID, end of November, beginning of December 2020, we had 235 COVID patients, plus another 120 or 130 other patients. So clearly exceeded the number of rooms we were running before the pandemic. Fortunately, we were able to do that because of an emergency mandate from the governor, which allowed us to use so-called non-licensed treatment areas, which included our tents. But we also converted other areas of the hospital to make more ICU beds. Before the pandemic, we operated 60 ICU beds. During the peak of the pandemic, at one point, I think we had 90 or 100 ICU patients. So other areas that could be easily converted were, one example, the GI suite, which had a large pre-procedure, post-procedure, as well as procedure rooms, got fully converted for COVID ICU care. In some cases, those were open treatment areas with curtains. They weren't closed rooms. But we were able to turn the entire suite negative by installing fans in the windows and sealing up doors. And we were able to add another 20, 25 beds. We also took an area of the pre-op holding area and made that into a COVID ICU holding area. And last December, when our ICU colleagues were simply overwhelmed, and we realized that we were ending up boarding a number of COVID patients in the ED in ICU status, we actually stood up our own ICU service. I rearranged our schedule and took 3 of our emergency physicians who were comfortable caring for COVID inpatients, took them out of the rotation for ED coverage, And we created our own ICU service to manage those patients we were holding anyway. But that also freed up our ICU colleagues upstairs so they didn't have to come to the ED and round. That service was up and running for about 8 weeks.
Mhm. I'm interested on the technical aspect of increasing the number of ICU beds. So where did the oxygen come from for all these patients?
Yep, great question. Oxygen was a big problem. We've heard about shortages of oxygen around the country. Locally, we had plenty of oxygen. The problem was getting it to the patient bedside. We, at one point, when we had 230 patients in the hospital, I bet at least 150 of them needed high flow oxygen. And delivering that amount of oxygen in the existing pipes became a huge challenge. Our oxygen farm, which consists of two large cylinders in the back of the hospital near the loading dock, had trouble keeping up. We had to have workers with water cannons or pressure washers standing out there knocking the ice off of the evaporator coils because they were getting so iced up that the flow was dropping. We then had a problem that the pressure in the pipes in the hospital, which should be around 50 psi, was dropping into the 30s because the demand on the system exceeded the ability of those pipes to carry the oxygen from the oxygen farm. So we actually took advantage of an emergency access point in the system. There's two ports on the outside of the hospital that were designed to keep the system running if we had to do work on the main oxygen tank. We set up two new liquid oxygen cylinders and fed the system simultaneously from one of the emergency access points, which happens to be right outside our EMS bay. But we were simultaneously feeding the system from the main feed as well as from the auxiliary point in order to maintain the oxygen pressure.
Good. Now that was a great point about the engineering capacities, and luckily you were set up to respond to the demand. But I see your ED room utilization plan, so maybe you want to go back to the changes in your actual ED department.
Right. Well, we were trying to maintain that separation between patients who were infectious and those who weren't. So we looked at our department and we actually turned it into zones. Without going into all of the details, what you can see are these large banks with yellow around them. These were all rooms that had windows to the outside. And a few of them were already negative, the ones in red color, but all of the blue ones did not have negative airflow. We converted all of those rooms to negative airflow by installing those fans and filters that I showed you earlier in the window of each of those rooms that weren't previously negative. So we greatly increased our numbers of rooms that could support negative airflow. And then we had a so-called dirty zone, which was pretty much the whole south half of our department. But we also had a clean zone, which included a parallel hallway on the north side that we would use to move non-infected patients. Oliver, this worked for a while, but at some point we couldn't tell who was and wasn't COVID positive. I'm sure many hospitals like us began testing all patients being admitted, and we started seeing patients coming in with other problems, maybe cholecystitis, who, when we tested them, it turned out they also were COVID positive. They just weren't exhibiting a lot of symptoms. So this helped us for a while, but at the peak, essentially the whole department was considered dirty, and we were consistently in our PPE. You didn't take off your mask for the entire shift.
Mm, wonderful. So now another question that I have, obviously you are heading a department in an academic medical center, and we're talking here on behalf of SAEM. So what happened to your research activities?
Yeah. Well, research was shut down by the institution at the beginning of the pandemic. Initial concern was maintenance of PPE. The hospital didn't want us burning through PPE for so-called unnecessary activities, and they considered our research personnel part of that unnecessary activity. We did manage to acquire some of our own PPE. We did outfit our research personnel with protective masks. But initially, all of our studies were shut down.
Mhm.
I made the argument to our school and to our hospital that COVID was also an opportunity for us to do some new important research related specifically to those patients. The first project that we resumed, in fact, was the project that we did with you because we were interested in looking at markers of infection in patients with COVID. And the sepsis shield study, or the precursor to that, was important to us to see whether we could predict and identify not only those patients who should show as being virus positive if they're infected with COVID versus bacteria positive,
Mhm.
but also to see if the severity index would correlate with their ultimate outcomes.
Mhm.
So we did get permission to resume research. But we had to go back to our IRB to solve some other problems. Our IRB did not want us taking a research person to the bedside of an infectious patient with COVID. We had to work out some new mechanisms for getting informed consent. That took several forms. One was, in fact, a video conference. We had set up video conferencing for families to visit with patients in house with COVID because they weren't allowed in. We were able to adapt that same video conferencing mechanism to do
Mhm.
informed consent between the research personnel and the patient, speaking to each other over a live video link. Uh, we didn't really want to take papers that the patient handled, the actual consent form that they signed, and hand that out. So we started taking pictures of the signature page of the consent form through the video or through the window of the room
Yeah.
so that we could continue the process.
Great. Now, again, congratulations also from our side to you, because you were actually the first site that started to enroll patients with COVID actually into our sepsis shield trial. So what about other opportunities in terms of treatment studies? We know the biologicals came, there's antivirals. So what were you able to implement and work with, industry?
Those of us, who are used to doing clinical trials and are known to others, started getting lots and lots of phone calls because many people in industry wanted to test their particular chemical molecule to see if it was effective in COVID. And we were eager to find new tools because, as you know, Oliver, the tools we had weren't great. They didn't produce great improvements in outcomes. I had many requests from companies with their novel monoclonal antibodies to see if we could quickly sign up and get those studies done. Unfortunately, because of some local limitations, the process for us, being a state institution and requiring local IRB sign off, means that it's a 6 to 8 week period really to get any new study up and running. The time pressure was so great from these companies that we were eliminated for many of the studies because they wanted to be up and running literally in 2 weeks using a central IRB with very rapid sign off. I believe some of my colleagues around the country were able to do that. Unfortunately, we were not. Having said that, we did participate, though, in one prospective randomized phase 2 trial of a new compound for COVID pneumonia. The compound is called Oxora. We enrolled 38 patients in this randomized trial. The trial is closed to enrollment, and the data is now being reviewed. And we hopefully will hear something in the coming weeks to see whether or not that was effective.
Great. One of the tools, obviously, that you would have to use to sort through the patients and make sure who has COVID and not are the diagnostic tests that are available in the country. So which of those tools between PCR test, antigen tests did you actually use, and how did this help you?
Sure. Availability of tests was a huge issue. We'll probably all remember lots of news coverage about not enough tests, can't get enough tests, states wanting more tests. And testing truly is important when you're dealing with a pandemic. You need to know who is and who is not infected. This became a choke point for us in the emergency department because besides COVID patients, we did continue to see other individuals. Now, I have to say, our total volume of patients dropped. Once we got past the big COVID surge, we saw a lot of hesitancy in the community for people that we would normally see with a bad headache, with their blood sugar out of control, with a skin or soft tissue infection. we saw many of them staying away from the hospital, and our numbers at one point dropped to 60% of our normal daily volumes after we got through the surge of COVID
Mm,
patients. Slowly, it's coming back. I'd still say we're at only at about 85% of our pre-COVID volumes. We got delayed in all admissions because every patient needed to be tested for COVID.
mm,
And we relied here on PCR. We did not have enough or good enough antigen tests, rapid antigen tests, particularly early on, that give you a result in 15 minutes. So we were relying on PCR testing with about a 2 to 3 hour turnaround time,
mm,
particularly because those tests were being done in batch mode in our main lab. And so between collection time, getting it to the lab, having enough to run a batch, and getting results, I would say almost every admission was delayed by 3 hours.
mm,
Uh, Patients who had to emergently go to the OR had a new step added during their resuscitation. There was a nurse who had to get a swab up their nose before they left for the operating room
mm,
because, if at all possible, they wanted a result before the patient completed the operation to know where to send the patient post op.
mm.
Same was true for the cath lab. If we had a STEMI going to the cath lab, in addition to the EKG, aspirin, Brilinta, heparin, they needed a swab up the nose to be sent
Mm.
for a COVID test before they left for the cath lab.
Yeah. Great. No, thanks for sharing those aspects. So now let's maybe, to get to the end of our discussion, let's talk a little bit about the future. And maybe before we talk about vaccination and maybe public health aspects, what would you wish to have in terms of diagnostic armamentarium? Is there any unmet diagnostic need that you can think about to change how we respond to a future pandemic?
Well, great question, Oliver, because I'm sure there will be future pandemics. I suspect we may have future surges of COVID. And given that we've experienced COVID-19 as a novel virus causing pandemic, there'll probably be future ones as well. Point of care testing is incredibly helpful and important to us in terms of maintaining our flow of patients. And tests that help us prognosticate a patient's course to understand who likely is going to need ICU care or who should go to the ICU, understanding which patients really should get broad spectrum antibiotics up front versus ones who may be only viral and we should save them broad spectrum IV antibiotics, both for cost as well as potential resistance issues. This would be very, very helpful. Now we are seeing some good rapid antigen tests that are more accurate than the ones that we had in the beginning. Having 10 or 15-minute results for COVID positive, negative, or for whatever the new virus will save us a lot of time on all of our patients.
Mm,
I also have great hopes for Sepsis Shield because having information that lets us prognosticate which patients are likely going to need ICU or should go to ICU up front versus those that are more likely to have a benign course would allow us to make better use of our limited resources.
great. So maybe at the very end, what do you think, how would you summarize lessons learned from this experience with the COVID-19 pandemic?
Well, we've learned that we need to maintain good quantities and stocks of personal protective gear. We've learned about the importance of having an increased number of negative airflow rooms, not only in the emergency department, but also in the hospital. As our numbers grew, we started doing whole floors that were negative airflow to try to maintain that separation. Those types of resources will be important in the future. We've folded up one of our tents, but we're storing it away because we may need to unfold it and use it again in the future. I also think there's a big role for our professional societies in sharing information. Some of the stuff we made up as we went, but a lot of things we learned by talking to our colleagues and hearing about their experiences and how they dealt with their surge in patients, how they dealt with the pandemic. I think we have a lot of lessons learned that probably need to be written down and memorialized and need to be passed along to those that come after us so that we don't have to reinvent the wheel the next time this happens.
Wonderful. I think this was a great final remark, and I want to thank you for taking time to talk to us, and also want to thank SAM for working on this webinar series. And thanks to everybody who listened. I hope you enjoyed. And again, this is number 7 of a series of webinars that Inflammatix is producing together with SAM. Thank you very much. Goodbye.
Thank you, Oliver.